Hello and welcome. This is week 6 and lecture number 30 of the knee injury rehabilitation course. In today's lecture, we will discuss the comprehensive approach to combined and multi-ligament knee injuries. We have already discussed each and every ligament of the knee and the rehabilitation protocol that is to be followed for them. In this lecture, we will just discuss the general principle for multi-ligament knee injuries. In today's lecture, we will cover the objectives of understanding the spectrum and classification of multi-ligament knee injuries or MLKIs. We will recognize the mechanism and common injury patterns. We will identify acute priorities and challenges in diagnosis and management of these injuries. We will also learn to differentiate between conservative and surgical approaches. We shall also learn evidence based phase wise rehabilitation strategies. We will appreciate the role of multidisciplinary care in functional recovery, and we will also apply criteria based milestones for safe return to sports. Single ligament injuries provide enough challenge to the rehab protocol. Multi ligament injuries raise the stakes completely. These cases often involve surgical reconstructions, longer immobilization, and a higher risk of complications. The rehabilitation has to be comprehensive, carefully staged, and often slower than the athletes would prefer. The goal isn't just return to sport, it's to restore a stable functional knee for the long term because the knee continues working for decades even after the athlete stops competing in sports. A structured and multidisciplinary approach is the only way to manage these complex injuries successfully. A multi-ligament knee injury involves at least two of the four major stabilizers of the knee, namely the ACL, PCL, the MCL, and the LCL or PLC complex. The Schneck classification describes knee dislocation and it is graded from KD1 to KD5 depending on which ligaments are involved. KD1 mentions only involvement of one cruciate ligament. KD2 is involvement of both cruciate ligaments. KD3 is involvement of both cruciate ligament and one collateral ligament. KD4 is involvement of both the cruciate ligaments and both the collateral ligament as well. KD5 is knee dislocation with periarticular fracture present. These injuries carry a higher risk of vascular and nerve damage, making early recognition absolutely essential. This Schneck classification helps us in guiding management and predicting complications. The MLKIs usually result from high energy or high velocity trauma, such as road traffic accidents or from contact sport injuries with violent force. Knee dislocations are common, though many are missed if they spontaneously reduce before presentation. While rare, these injuries are devastating, often affecting young and active patients. Multi-ligament knee injuries are relatively rare compared to single ligament injuries, usually constituting less than 10 to 15% of all ligamentous knee injuries present. Although among trauma referrals or surgical cases, the incidence of multi-ligament knee injuries is higher than that of single ligament injuries. In case of multi-ligament knee injuries, the first priority is ruling out vascular compromise, especially popliteal artery injury. The popliteal artery originates as a continuation of the femoral artery. It travels through the popliteal fossa behind the knee, branching to supply the knee joint via its genicular branches. And it also supplies the posterior leg muscles through its muscular branches. The artery terminates by bifurcating into the anterior and posterior tibial arteries. It's, it supplies blood to the lower leg and foot. Injury to the popliteal artery can be limb threatening. Peroneal nerve function must also be checked early. Gross instability often requires urgent stabilization. An MRI is essential to fully define the injury pattern and the extent of the injury. It will also help to guide the surgical planning in such cases. Conservative treatment is reserved for low demand non athletic subpopulation, but most multi-ligament knee injuries require surgery. The debate continues between acute, staged, and delayed surgery, each having its own pros and cons as discussed in previous lectures. However, in multi-ligament knee injuries, a staged approach is most preferred. The primary goal is to restore stability without causing stiffness of the knee joint. Stiffness or arthrofibrosis is a common complication in cases of multi-ligament knee injuries. The treatment decisions must be individualized on case-to-case basis. Most grade 3 isolated cases of ACL and PCL injury require reconstruction, often with grafts. Low grade collateral ligaments are often conservatively managed, but the PLC injury may need a repair or reconstruction depending on the injury pattern. Sometimes surgery is staged, for example, repairing collaterals in an acute knee condition and then addressing the cruciates later once the swelling subsides is a good example of a staged surgery. Complex reconstructions demand longer and more cautious rehabilitation approach in individuals with multi-ligament knee injuries. Rehabilitation is particularly challenging because different injured structures often require conflicting protocols. For example, an MCL repair may need early range of motion of the knee, while a PCL reconstruction demands range of motion restrictions. Then there is also a high risk of stiffness or arthrofibrosis. Weight bearing restriction in such cases are prolonged. The rehab process is long and the psychological burden on patients is significant. One can only imagine the dilemma and mental state of an active athlete who is unable to train on the field due to his injury. The detailed and specific rehab plan for each structure has already been covered in detail in the lectures conducted previously. I will just highlight upon the general principles of rehab of each phase of a multi-ligament knee injury. The acute phase focuses on protection and decreasing the symptoms of pain and swelling. If you recollect, we follow the police protocol in this phase. Bracing of the knee is essential, often with restricted weight bearing. Gentle, passive ROM exercises are introduced within safe limits to prevent stiffness. Isometric quadriceps, glute, and core strengthening exercises help to maintain muscle activity without stressing upon the healing structures. In this phase of the rehab, we focus on gradual weight bearing progression. Depending on the surgical protocol the patient has undergone, the ROM or range of motion of the knee is restored cautiously, and it again depends on the surgical protocol. Strengthening progresses with close kinetic chain, low load drills. In this phase, we can also start balance and proprioceptive training to restore the joint position sense. This helps the patient to regain joint awareness and stability. And with stability, the patient also gains psychological advantage and confidence. The phase 3 of rehab focuses primarily on restoring functional strength and endurance. Neuromuscular training is emphasized to prevent faulty movement patterns. The emphasis is not just on the number of repetition and sets completed, but mainly on the quality of the movement and how close is the action replicating the one from before the surgery. Controlled agility and eventually sport specific drills are introduced in this phase. Low intensity plyometrics like skipping and squat jumps are started and eventually progressed into higher intensity exercises like box jump and depth jump. Progression is slow and cautious and guided by objective criteria. Monitoring for specific symptoms is essential before progressing to return to sport phase. Return to sport usually takes a minimum of 9 to 12 months of a structured and well planned rehab protocol. The criteria includes full range of motion in weight bearing, more than 90% of strength symmetry between the injured and the uninjured limb, and passing the functional test without any hesitation and with good quality of movement. Unfortunately, despite best efforts, many patients cannot return to the pre injury athletic level, and long term osteoarthritis risk is high in such patients. Counseling and realistic expectations are vital and play a key role in patients' adherence to the rehab protocol. Multi-ligament knee injuries in athletes demand coordinated input because of their complexity and high risk of developing complications. The orthopedic surgeon determines surgical timing, the graft's choice, the decision between repair and reconstruction, and this needs tailored to the demands of the sport of the athlete. The vascular and plastic surgeon are vital when arterial compromise or soft tissue coverage issues arise. Sports physiotherapists drive stage criteria-based rehabilitation, focusing on range of motion restoration, neuromuscular control, and progressive loading. Strength and conditioning specialists bridge the gap from rehab to sport, restoring explosive strength and sport specific performance. Sports psychologists address fear of re injury, motivation, and mental resilience during the prolonged recovery period. A sports nutritionist optimizes energy intake, protein intake, and intake of micronutrients to support ligament healing, muscle recovery, and lean muscle mass preservation. A sports biomechanics expert analyzes movement patterns to correct compensations, reduce re injury risk, and tailor sport specific load progression during rehab. The sports medicine specialist, who is also the team physician, integrates all disciplines, ensuring return to play decisions are evidence based and athlete centered. With this, we come to the end of this lecture as well as the week 6 in your knee injury rehab course. The key takeaways are multi-ligament knee injuries are rare but devastating if mismanaged. For example, if acute assessment fails to recognize vascular or nerve injury, the consequences could be dire. Surgery usually required in these cases, and a staged approach is often considered best. Rehabilitation is cautious, prolonged, and requires a multidisciplinary approach. Return to sport is possible, but sometimes it is not guaranteed. These are some of the references that I have used in this lecture. With this, we finish week 6 of the rehab course. We shall now progress to week 7, where we discuss sport specific conditioning required for return to sport. Thank you and goodbye.